Hello, I'm Dr. Steve Karstensen, Chief Dental Editor of Dental Sleep Practice, a MedMark publication. Welcome to an educational discussion and Q&A with Dr. Hugh Cassiere. In our webinar today, we'll discuss the role of skin pigmentation in pulse oximetry. Associated with this presentation is a free CE quiz. At the end of the webinar, we will email all registrants the presentation recording along with instructions on how to access the CE quiz. Before we get started, I would like to invite everyone to use the Q&A feature in the control panel to ask any questions. They'll be answered at the end of the session as time permits. And now I'm pleased to introduce our speaker. Dr. Hugh Cassiere is a triple board certified physician in internal medicine, pulmonology, and critical care medicine. He currently serves as Director of Critical Care Services at South Shore University Hospital and is an Associate Professor of Medicine and Cardiovascular and Thoracic Surgery at Zucker School of Medicine in Hofstra and Northwell, all in New York. Over his 28-year career, Dr. Cassiere has specialized in the care of medically and surgically complex cardiovascular intensive care patients, working alongside leading cardiac anesthesiologists, surgeons, and cardiologists. He previously directed critical care services at Sandra Atlas Base Heart Hospital and held numerous leadership roles across Northwell Health, overseeing quality, rapid response, and ICU initiatives across multiple campuses. Nationally, he serves as chair of the FDA's Anesthesiology and Respiratory Devices Panel and contributes to several other medical device panels. Dr. Cassiere earned his MD at Stony Brook School of Medicine and completed residency and fellowship training at Winthrop University Hospital. Thank you so much for joining us, Dr. Cassiere. I'm so excited for your topic. Now I'll turn it over to you to learn more about it.
Thank you for that great intro. Again, just to reset, it's a pleasure being here and sharing some of this knowledge. We're going to be talking about the role of skin pigmentation and pulse oximetry with towards the middle to the end of the talk with an emphasis on consideration for dental sleep medicine. What I thought would be a great idea is just to, at the completion of this webinar, hopefully we'll describe the mechanisms of action of pulse oximetry. Consider some of the limitations of pulse oximetry as it applies to skin tone and the applicability to dental sleep practice, in particular the apnea-hypopnea index and our new thing called hypoxic burden. And then we're also going to, hopefully round up the talk with assessing the FDA guidance document and how this can impact practice. I'd just want to give the big picture here. Pulse ox is ubiquitous throughout healthcare. It's used probably tens of thousands of times a day across the United States, probably over 100,000 times a day worldwide. It's also frequently used in dentistry. You guys know that. You use it for sleep apnea, sedation dentistry, and assessment of blood supply. That's great. It's a great device, but what is the problem? The problem with pulse oximetry, it's been around for so long that most people have forgotten how it works, and along with that, what the limitations are. It's not a perfect device. Here's a little history. When was oximetry discovered? Back in 1942 by an American physiologist named Dr. Glenn Millikan, who was a aviation researcher, actually a military aviation researcher. And there's no coincidence that it was discovered in 1942. 1942 was during World War II. One of the issues during World War II is our fighter pilots, when they're engaged with dogfights, would literally pass out from hypoxemia at high altitudes and crash and die. So Glenn Millikan invented oximetry. He coined the term oximetry. And as you can see by this little picture, at that time, it was a device that was put on the ear that measures static oxygen hemoglobin concentration in the pilots. And they were able to do that, and they would supplement the pilots with oxygen so they wouldn't die during dogfights. That was the genesis of oximetry, not patient care. It had nothing to do with patient care. It had to do with combat. A little bit more recently, there was a significant advancement by a Japanese bioengineer, Dr. Toko Ajoya, back in 1974, who invented what we would consider the first clinically available pulse oximeter. And as you know, it's a life-saving device that clips on the finger and shows the oxygen level in the blood in real time. It wasn't static, it's continuous. It's hailed as one of the greatest advancements in patient monitoring, probably second only to continuous telemetry or cardiac monitoring. So much so that instituting pulse oximetry led to a 90% reduction in anesthesia-related fatalities. Let me say that again, a 90% reduction in anesthesia-related deaths with the use of pulse oximetry. With that said, it became the fifth vital sign in the operating room. No surprise there, with heart rate, respiratory rate, monitoring, and temperature. What does the pulse ox really do? It gives us a quick, rapid estimation of peripheral oxygen saturation, provides very valuable clinical data in a non-invasive, very convenient manner, no needles involved. I'm an ICU guy. We use the pulse ox to calculate this fancy formula, which is the oxygen delivery formula, which can help us figure out patients in our cardiovascular ICU, what's wrong with them and how to fix them. This other equation called the Fick equation is also used by most cardiac ICUs around the world to calculate cardiac output. So it can give you really great information. Well, here's some of the critical assumptions that we make when we utilize the peripheral O2 sat. We assume that the peripheral O2 saturation is equal to something that is really physiologically important, and that's the arterial oxygen blood saturation, which can only be obtained by an arterial blood gas or an arterial blood stick. Very inconvenient to stick patients over and over again to get arterial blood to find out what their arterial saturation is. The pulse ox is supposed to simulate that or give us a representation of what that number is. Now, just to level set things, there are two types of oximeters really on the market. What we consider the prescription use oximeters. These are the ones that are formally FDA approved, the ones that you're using in your office, the ones that are in the hospital. They're FDA guidance on that, and they have to meet certain criteria before they get the approved. And then there's the over-the-counter pulse oxes, the ones you go on Amazon.com or whatever you do, wherever you buy your stuff online. And those are the ones that you just buy over the counter that aren't quote unquote FDA approved. They're only used for wellness and fitness. So there are two types of oximeters. The bulk of this talk is going to be on hospital grade, what is considered high quality oximeters, not the over the counter ones. And I have a slide or two at the end to show you why, if you're using the over counter pulse oxes that aren't truly FDA approved, you may want to think twice about that. Well, how does the pulse ox work? It's actually a simple device physics-wise, right? You guys know you put a probe on the finger, you shine light that's emitted by an LED, and then there's a photodetector on the other side of the finger that picks up the light. There are two different light frequencies that are used in all pulse oximeters on the market. It's the 660 or the red spectrum and the 940 or the near infrared spectrum. And what this light does is it's a differential absorption of the light across the fingertip, and deoxygenated and oxygenated blood have different absorptions of wavelengths. And what do I mean by that? The 660 nanometer light frequency is attuned to the deoxygenated blood. It likes to look for the deoxygenated blood. The 940 is in tune for the oxygenated blood. So what the pulse ox does is it looks at the deoxygenated, the percent of deoxygenated blood that's being absorbed with the light frequency and the 940, which is the oxygenated one, and it comes up with this ratio called the R ratio. And this R ratio is really based upon the pulse and non-pulsatile blood flow. The AC looks at the pulsatile blood, what portion is deoxygenated, which portion is oxygenated. The so-called DC, which looks at the blood that's in the tissues, the capillary blood and the venous blood, looks at when there is no pulse. And based upon this, there's a ratio that's come up that's spit out by the pulse oximeter. And that ratio is used with a calibration curve to help the machine put out what the pulse ox reading is. Now, let me go over this again. The machine calculates this R ratio, and it has a number. But then there's a calibration curve that gets programmed into the pulse ox to help the pulse ox spit out what the peripheral pulse ox reading is. How do they make these calibration curves? Who are they using to calibrate the device on? It's in healthy subjects. And in these healthy subjects, they do what's known as desaturation studies, where they desaturate patients anywhere from 70% to 100%, and they make this calibration curve. And based upon this calibration curve, you have an R value and now a calibration curve. And then basically what the machine does is the machine looks at what the R is, what the calibration curve is that's programmed into the machine, and it spits out a peripheral O2 sat. A little bit more about this calibration curve on the next slide. Here's how it's made. Again, healthy volunteers breathe gas mixtures with different oxygen levels. There are blood samples taken at each oxygen level. The ratio of light absorption at these two different wavelengths is measured for each sample. This ratio is correlated to the oxygen saturation measurements by these blood gases that you did. The data from many volunteers, these healthy volunteers, is all averaged to create this calibration curve. This calibration curve is then programmed into the pulse ox, and that's how you get your pulse ox reading. Just a little foreshadowing here. These healthy adults in the past that have been used to make this calibration curve have mostly been done in lightly pigmented individuals. In other words, these calibration curves have been done in mostly whites with light pigmented, not in darkly pigmented individuals. And here lies in what we're going to be talking about. So what we really want to know physiologically is what this oxygen saturation in the blood. You can only get that with a blood gas. You got to stick the artery. The peripheral O2, the pulse ox is supposed to be an indicator of what that is. So there's a critical assumption that we make when we're using the pulse ox. That critical assumption is the peripheral pulse ox reading correlates with the arterial oxygen saturation. That's what we really want to know. Unfortunately, it's been known since the 1990s that this critical assumption may not necessarily be true in patients with darkly pigmented skin. In other words, there's something called occult hypoxemia, where your peripheral O2 sat is quote unquote normal, but if I were to do a blood gas in you, your arterial oxygenation is really bad, sometimes less than 88%, which is physiologically debilitating for patients. We're going to talk a little bit about why this topic is hot, but it's been around for a long time. This is an article from 1990 in the journal Chest, which is the premier journal for the American College of Chest Physicians that all pulmonary and critical care people read. And not only was it a premier journal, but it was done by a researcher named Dr. Martin Tobin, who's an icon in pulmonary critical care, has written textbooks on mechanical ventilation and all kinds of important things in pulmonary critical care. What did Dr. Tobin find back in 1990? The title of his study was Reliability of Pulse Oximetry and Titrating Oxygen in Ventilator-Dependent Patients. What did Dr. Tobin find 35 years ago? He found that there was 2.5 times inaccuracies in Black patients than compared to white patients. Let's put this in context, what that means. That they observed if you had an O2 saturation on your pulse ox of 92%, which we most consider as normal, is okay, not great, but it's not horrible. It has a safe partial oxygen level of 60 in the blood, which we also consider as safe. If you were white, 92% of the patients were in the safe oxygen zone. If you were Black, only 50% of Black patients had a normal oxygen level with an O2 sat of 92%. Again, 2.5 times inaccuracies in dark skin. This was back in 1990, 35 years ago. What was the response from clinicians? What was the response from the FDA? What was the response from device companies? Chirp, 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 crickets, nothing. There was nothing done, no outroar, no uprising, nothing. So what happened? Fast forward to 2020. What happened in 2020? Well, I can tell you in my neck of the woods, March 2020 was the beginning of the COVID pandemic, and we were inundated with COVID-19 patients, and I'll tell you why in a second. But this article was published December 2020 by a researcher out of the University of Michigan. His name is Dr. Strogan. And what did he find in 2020? Almost the same exact thing that Dr. Tobin found in 1990. He found nearly 3 times the inaccuracies in blacks. They were diagnosed with this occult hypoxemia than white patients. Again, let me highlight 3 times the inaccuracies in black patients compared to white patients. They found an entity called occult hypoxemia, which I mentioned before. It's when your peripheral O2 sat is 92 to 96%, which is pretty good, pretty normal. I'm happy with that. But if you did a blood gas, their arterial saturation was less than 88%, which is profound hypoxemia. And there were some patients who had a O2 sat of 97%, and if you did an arterial blood gas, their oxygen saturation was less than 70%. So this is occult hypoxemia, 3 times more common in blacks or darkly pigmented individuals. Again, since 1990, again, COVID, there's a resurgence for this. This is just a graph of that showing the 3 times more likely to be inaccurate with darkly pigmented skin than lightly pigmented skin with pulse oximeters. And here's where we're talking about pulse oximetry can lead to inaccurate readings in patients with darkly pigmented skin, also with nail polish. You guys know, right? Black, blue, and green is horrible for pulse oxes. Ambient light, you always want to cover the pulse ox up so it doesn't have ambient light. That can interfere. But the big thing is skin pigmentation. Again, this has been known for 35 years. Well, what's the difference between darkly pigmented and lightly pigmented skin? You don't need to be a rocket scientist to know that it's melanin, right? So here's a microscopy samples of the skin of the nail bed of patients who are white and they have less melanin. If you're Asian, you have a little bit more melanin. And if you're black, you have a lot of melanin. So the big thing that is going around is that it appears that melanin is the culprit in terms of causing inaccuracies in darkly pigmented individuals with pulse oximetry. Now, why is that? Well, it just so happens, coincidentally, that 660 spectrum of light, the one that is supposed to be looking at the deoxygenated blood, is adversely affected by melanin. In other words, you will underestimate your deoxygenated blood when you're darkly pigmented and give you a false reading on the pulse ox, especially if you do not have calibration curves that use patients who are darkly pigmented with melanin and you program that into your pulse ox machine. So no coincidence. And the other thing is patients who are darkly pigmented, only 10% of their melanin is in their nail bed. There are some places that use pulse ox on the forehead and on the earlobe. Those have 100% melanin. So again, a lot of the data I'm going to be talking about is on the fingertip, which is only 10% of darkly pigmented individuals' melanin. Well, we got to talk about COVID. I hate to do that for a dental group, but what was particular about COVID? Again, 2020 really blew this whole pulse oximetry and accuracies things up. And the reason for that, long story short, is COVID caused what's known as acute respiratory distress syndrome. There's a viral phase, and then the body tries to fight the viral phase, and then you have a host inflammatory phase that actually attacks your body's attacking itself, and it leads to this acute respiratory distress syndrome, which leads to profound hypoxemia and respiratory failure. I gave a separate talk for other groups on the critical care management of COVID-19. One of the things I talk about is occult hypoxemia, but this is really important. And it's really important because of 2 drugs that are used for COVID-19. One is remdesivir and the other one is dexamethasone. Now, this is an algorithm that's used to help treat patients with COVID-19. This was my health system's guideline. Other health systems had the same. And what you notice on here, part of the algorithm in terms of not only triaging patients with COVID-19, but figuring out if they need therapies or not, was based upon what? Pulse oximetry. It was the first time, probably in a long time, where pulse oximetry drove the process of not only do patients get admitted to the hospital, but do you treat them? And what do you treat them with? Again, you can see the pulse oximetry guidelines right here in front of you. Now, this helps explain some of those racial disparities we saw during COVID. Blacks, Hispanics, Asians had substantially higher rates of infection, hospitalization, and deaths compared to whites. Let's put some numbers around this. If you were Black, you had 3.3 times the risk of being hospitalized because of COVID and 2.5 times the death rate compared to whites. If you were Hispanic, you had 4 times the risk of hospitalization and 2.5 times the risk of death. How about if you were Asian? You had 2.1 times the risk of hospitalization and double the risk of death compared to whites. Now, what's the magic behind that? Pulse oximetry drove hospitalizations, treatments, and other therapies for patients. So if you were darkly pigmented, which Hispanics are, Asians tend to be, and Blacks for sure, you had increased risk of mortality. And in other words, dexamethasone, which is the drug that decreases mortality in COVID-19, you were denied COVID-19 therapies. Now, what does this have to do with anything else outside the ICU or the hospital? Well, it just so happens pulse oximetry is also used to qualify for supplemental oxygen guidelines. It's also used to qualify for disabilities and compensation. It's also used to gauge patients' severity of disease. And there's some data in the transplant literature that pulse oximetry could lead to patients not being listed for transplants. Well, this is a dental conference about sleep apnea or sleep medicine. There may be a lack of recognition of sleep disordered breathing. And why is that? Pulse oximetry plays a role in the diagnosis of sleep apnea, and it also plays a role in gauging the severity of sleep apnea. So pulse ox is used to calculate the apnea-hypopnea index. Although there's no oximetry criteria for apnea, there is an oximetry criteria for hypopneas. Anywhere between 3 or 4% of desaturation is considered hypopnea with a low airflow. Now, just to break things down a little, most patients who get diagnosed with sleep apnea get diagnosed more so because of hypopneas, not apneas. About 65 to 70% of the AHI in patients may solely come from hypopneas. Now, what would happen if you don't pick up desaturations in patients because of skin pigmentation? Now, there's a new concept out there, and you guys have probably heard this, hypoxic burden. It's a new concept in sleep medicine. The thought is it may improve quantification of nocturnal hypoxia. Now, this is a very busy slide that I'd like to take a little time to talk about why hypoxia is important, especially in sleep medicine. You guys know the routine, right? Obstructive sleep apnea, you obstruct the airway. There's an inspiratory effort in the lung. It leads to hypopneas and apneas and then arousals. And a lot of this is correlated with desaturations. And then you get hypoxia repeatedly throughout the night. What does hypoxia do? Hypoxia does a whole bunch of adverse effects in the body. It could lead to hypoventilation. And hypoventilation over decades can lead to pulmonary hypertension. How about the liver? You can even have adverse effects of hypoxemia in the liver by increasing fatty infiltration of the liver, which is newly shown to be a big burden in the population, and hypoxia can cause that as well. It could also lead to worsening of central obesity and hyperlipidemia. Hypoxia has been correlated with pancreatic dysfunction and insulin resistance. Clearly, there's an association with repeated bouts of hypoxemia and endothelial dysfunction leading to arterial hypertension, acceleration of arteriosclerosis, platelet dysfunction, and peripheral vascular disease. Well, how about the brain? The brain's not spared either. There's an increased burden of strokes and ischemic attacks. It can interfere with memory and cognition. Again, obstructive sleep apnea can cause hypersomnolence or sleepiness. Well, how about the heart? It causes endothelial dysfunction, but also causes myocardial dysfunction. It could lead to myocardial infarctions, heart failure, and there's really good literature on leading to atrial fibrillation. How is nocturnal hypoxia picked up? The apnea-hypopnea index, right? That's how you diagnose sleep apnea. There's also something called the total sleep time below 90%. There's also the oxygen desaturation index. But then there's this newer thing, hypoxic burden, which has kind of come to the forefront. We'll talk a little bit about that. Unfortunately, again, I want to emphasize this. There is no data, this is 2025 coming into 2026, on how skin tone inaccuracies with pulse oximetry impact the diagnosis or severity of obstructive sleep apnea, especially using the apnea-hypopnea index. Let me say that again. We do not know. I gave you a whole bunch of data on how the pulse ox inaccuracies can lead to morbidity and mortality in the non-sleep medicine population, but there's no data to date showing how the impact of pulse oximetry inaccuracies can affect sleep medicine. And there's no data on how it impacts the calculation of this hypoxic burden. Now, before we talk about the definition of hypoxic burden, it's probably going to turn out to be it's going to be a better measure of true impact of hypoxemia during obstructive sleep apnea episodes, and it correlates with the following adverse outcomes. The more hypoxic burden you have, the more cardiovascular morbidity and mortality. The more hypoxic burden you have, the higher the incidence of heart failure. The more hypoxic burden you have, the higher the incidence of stroke. Now, what is this total hypoxic burden? It's the area of all individual desaturation events that are summed up. It's then divided by the total sleep time to give a total hypoxic burden that's usually expressed in units of percent per minute per hour. In other words, not all desaturations are created equal. You may have a desaturation that lasts 10 seconds. Someone may have a desaturation that lasts 1 second, but using the AHI, or not more than 3 seconds, you wouldn't tell that the burden of the 10-second desaturation is much worse than the 3-second one. This is why I believe total hypoxic burden is a much better measure of the severity and the toll that obstructive sleep apnea takes on patients. Now, why is this particularly important for African Americans or darkly pigmented individuals? Look at the perceived incidence of obstructive sleep apnea in the African American population. It could be anywhere between 20 and 25% of African Americans having significant obstructive sleep apnea. Now, this is age related, right? The older you get, less than 50, it's a burden. 50 to 59 is higher. 60 to 69 is higher, and greater than 70, it's even higher. And if you're a male African American, if you're greater than the age of 60, it could be as high as a 35% prevalence of obstructive sleep apnea. Now imagine having that patient population and having a device that may underrepresent, underdiagnose, and worst case scenario as well, underappreciate the severity of the disease. That's pretty scary. So what is the FDA doing about it? Again, I gave you data that goes back to the 1990s, but because of the pandemic, there's been a resurgence of trying to fix this problem. So once that article got published in the New England Journal of Medicine in 2020, showing that there's an issue with pulse oximetry and skin tones, the FDA put out a advisory in February of 2021. Again, it took them 3 months to do this, 3 months to let providers know there's an issue with pulse oximetry in darkly pigmented individuals. Then it took them a year to convene a panel of experts. I was a part of this panel in November 2022 advisory panel, and they wanted us to comment on whether pulse oximeters were inaccurate in skin pigmentation, which we told them absolutely there is. And then a year later, they put out a discussion paper for the public and the device manufacturers to take a look at what we discussed at the 2022 meeting. And then they convened another panel back in February 2024. I chaired this panel meeting where they wanted us to give recommendations on how to fix this problem that's been going on for 35 years. This is how slow things work. So what did the FDA do? The FDA gave us all the data. There were over 28 publications they gave us to take a look at. Some of them were systemic reviews, cross-sectional studies, retrospective studies, and lab studies. Here's just a sampling of them. Almost every study we looked at showed significant disparities in skin pigmentation and abnormal pulse ox readings. There were some real world studies that looked at this. If you had what I defined as occult hypoxemia, you had an increased mortality rate. If you were African American and had occult hypoxemia, your death rate was almost 3 times higher than whites. 3 times higher than whites. This is another study that looked at almost 80,000 samples, 80,000 patients, and almost 90,000 samples. And what did it show? Again, over and over again. Now, these are across all pulse oximeter companies, all device companies. If there's a device company that tells you their pulse ox is not a problem, I would not believe them at all. Now, here's a very profound one. This is an article of the best 15 articles that the FDA had to give to us. Out of the 15 articles, 14 of them showed significant abnormalities in pulse oximetry and skin tone. Again, 14 out of the 15. And the 15th article that said there was no issues was a poorly done article, although it was one of the best in the literature. Again, not to keep hammering away at this, but again, those with this hidden or occult hypoxemia had excess mortality that was statistically significantly worse in blacks than whites. And again, just to come back to COVID, which reignited this, if you had COVID-19 and you were darkly pigmented, whether you were Black, Spanish, or Asian, you were almost 30% less likely to get COVID therapies that were shown to improve mortality and morbidity. Again, compared to whites, all because of pulse oximetry and accuracies. Now, I talked a little bit about over-the-counter pulse oxes. This is a very busy slide. The only thing I want you to pay attention to is the right-hand side, which is accuracy. This was an article that looked at the 10 best over-the-counter pulse oxes that you can buy without a prescription. Now, look at the accuracies of these devices in picking up hypoxemia. The FDA considers a device to be accurate if it's above 97%. Not one of these over-the-counters met that criteria. Some of them had 60% accurate. The best one was 91% accurate, but all of them were miserable at picking up hypoxemia. So these over-the-counter pulse oxes, no surprise they're not quote-unquote FDA approved, were horrible at picking up correlating your blood gas data with your peripheral pulse ox. This is another slide from the same article. Again, it's very busy. I want you to pay attention to the right, the accuracy. This looked at different thresholds. Well, was it good at picking up O2 sats of less than 92%? Or how about less than 94%? If you take a look at the accuracy numbers, these over-the-counter pulse oximeters were horrible. There were some of them was like almost flipping a coin if they were hypoxic or not. So I beg you, if you use these devices clinically, I would not use them clinically. We already have a problem with the quote-unquote best hospital grade pulse oxes. These take it to a different level. So these over-the-counter pulse oxes, please don't use. Unfortunately, A lot of these were used during the pandemic to help manage patients, which is probably one of the reasons why there's so much excessive mortality rates in patients with darkly pigmented skin. Well, FDA guidance. What's this FDA guidance, right? So FDA guidance is, before 2013, you didn't even need to worry about skin pigmentation to get your device approved by the FDA. And the problem with the FDA is the FDA is slow. The previous guidance document was approved in 2013. We'll talk a little bit about that. That draft document came out in 2007. It took the FDA 6 years to finalize to 2013 guidance document that was supposed to address skin pigmentation issues. 6 years, which is way too long, even though we've known since the 1990s that skin pigmentation and pulse oximeters lead to inaccuracies. Well, again, like I said, before 2013, you didn't have to mention anything about skin pigmentation. You get your pulse ox approved. Well, how about after 2013? The FDA thought they fixed the problem with their 2013 guidance document, and here's why it was a joke. The FDA, after 2013, told device companies, let me say this again. These devices are used tens of thousands of times a day, hundreds of thousands of times worldwide a day. This was the FDA's guidance. You needed to just have data on 10 people, 10 healthy adults. And by the way, we know there's an issue with skin pigmentation. By the way, throw 15% of those people you check, make sure they have darkly pigmented skin. There was no guidance on that. You could do whatever you want. I do a lot of running. During the summer, I run outdoors. I'm very darkly pigmented. During the winter months, I do my running indoors. I'm pretty much lightly pigmented. I could be a candidate for both testing for the 2013 guidelines to approve pulse oxes for the FDA. And these guidance documents are in effect right now. So all you need is a small number of participants. They're healthy, non-hospitalized. Darkly pigmented was left up to the device manufacturers to figure that out on their own. And even if you had a device that was inaccurately in darkly pigmented individuals, they pooled the data together so that the data, even if it worked miserably in the darkly pigmented individuals, their devices would get approved because they pulled the data with the other lightly pigmented individuals. So the 2013 guidance document to get pulse oxes approved, which is still in effect today, did nothing to correct the inaccuracies of pulse oximetry for darkly pigmented individuals. And that's why we had the issue during the COVID pandemic with pulse oxes leading to increased mortality rate and inaccuracies in African Americans. Now, how about now? The FDA put out a new guidance document in 2025, January. Hopefully, it's not going to take 6 years to get approved like the 2013 one did. This was based upon that the meeting that I chaired to try to help the FDA come to some agreement on how we're going to fix these inadequacies of pulse oximetry in darkly pigmented individuals. Unfortunately, it's still a draft document, and we're in towards the end of 2025. It still has not been approved by the FDA to be the new guidance document. Well, what's the difference now? Now, there's a big difference. The 2013 guidance document, which is in effect, which I think is a joke, where you only needed to test on 10 people and 15% of them had to be darkly pigmented. You figure that out on your own. We told the FDA, hey, wait a minute. This device needs to be checked on a lot more people, at least 150 participants. You need to have over 3,000 data points looking at this device. And none of this darkly pigmented, you figure it out. We want you to use a subjective and objective measure of skin pigmentation. The subjective measure is something called the monk skin tone, which is at the bottom where you see to the left is lightly pigmented and to the right is darkly pigmented. That's a subjective scale. You need to use that. You also need to use objective measures. Use a device that measures skin tone, a colorimeter. So we wanted the device companies to do subjective measures, the monk skin tone scale, and objective measures, a colorimeter to actually measure with the skin tones when they're testing these individuals. Not only that, but we're going to require you to have from 1 to 4 lightly pigmented cohorts, 25% of the patients you check, people you check, the 5 to 7 moderately pigmented, at least 25% represented in that group, and then the 8 to 10, the highly pigmented people, you need to have at least 25% of your cohort that are tested in that group. So not only subjective, objective measures, you need to have the right amount of people in those buckets to make that calibration curve. Again, just to emphasize the difference between the before and after, the 2013 guidance document was really loose, which is why we still have an issue with pulse oxes on the market. And then the bottom one, where we want at least 150 subjects tested over 3,000 data points. 25% of the participants have to be in each of those skin tone buckets. You have to have at least 50% of your patients or participants be in that monk skin tone 8 to 10 group and have really high colorimetry measures on the forehead where you have 100% of your melanin to be included in that testing group to make that calibration curve. The calibration curve is where it all is. If you don't have fair representation of darkly pigmented individuals when you make your calibration curve, your pulse ox will spit out falsely elevated pulse oxes because that you're not representing enough melanin in your calibration curve. And again, not just subjective measures, we want objective measures. And by the way, which we really haven't talked about, there are sex differences in terms of pulse oximeters. Women in general have smaller fingertips than men. And since this is a light-based technology, you can have more light scattering if you have more quote unquote fingertip than if you don't. So we're going to require for the first time fair representation of gender. We want greater than 40% to either be men or women so that when you make your calibration curve, you're accounting for not just skin pigmentation, right, to make that calibration curve, but also you're also going to account for this light scatter, which you can get for varying varying finger sizes, which is different in males versus females. So this is how we're going to try to fix the problem moving forward. Now, in summary, I talked about a lot of this. Pulse oxes are used, again, they're ubiquitous, they're woven into the fabric of medicine and dentistry. We're not even aware of their limitations. I hope I've shed some light on that. Stay abreast of the new FDA policy changes. I'm hoping by the end of the year they're going to approve that. They're going to approve the new guidance document. Not sure if they're going to though, so this is going to be an ongoing problem. So pay keen attention to your darkly pigmented patients when you're treating them, whether it's for whatever you're doing for them, whether it's a dental appliance for their sleep apnea or trying to do some dental work for them. Just pay attention to that pulse ox reading. And again, I appreciate this time that I'm given to discuss this topic. And just so you know, this is an ongoing issue. And I will end this by saying, even when the FDA comes out with their new guidance, it's going to be very stringent on getting pulse oxes approved. It does nothing for the pulse oxes that are on the market and the ones that are in your office. So even though you may hear the FDA approved new guidance that are really stringent on pulse oxes, it may not have any effect on the pulse oxes you're currently using unless you decide to buy a new pulse ox, and then you talk about economics. So just FYI, it may not fix the total problem because there's going to be a lot of pulse oxes that are still on the market that haven't met the new guidance, stringent guidance criteria. They only adhere to the 2013, which is totally inadequate. Now, with that said, that's the end of my talk, and I'd be happy to answer any questions.
Well, Dr. Cassiere, that was as fascinating as I was hoping it would be. So thank you very much for this. And one of the aspects I've paid attention to over a lot of years is the sleep apnea part and the machines that measure the numbers that we pay attention to, HI so far and ODI. And I've realized that most of them are running off of pulse oximetry. At least it seemed that way to me, and you just confirmed all that. Are you familiar with those devices in any way?
Yeah, so that's the scary part of this. I gave a lecture to the National Sleep Conference, and I had mentioned to them that there is no data in the sleep medicine literature looking at pulse oximetry and the diagnosis and gauging the severity of sleep apnea. Now, for me, that's scary for two reasons. One, there's no data. This could really have a big impact on diagnosis and under treating people. And sleep apnea is a huge burden. And the second thing is there's a big move for outpatient diagnosis and outpatient sleep studies.
Mhm.
What is the validity of, I'm talking about hospital grade pulse oximeters that aren't working well.
Wow.
What about these devices you're going home with? And again, when we talk about desaturation, you need to desaturate between, less than 90% on your pulse ox to count. Well, how about, first of all, you really are hypoxic, but your pulse ox on your finger says you have 96%, and you may desaturate if you have some kind of hypopnea or apnea, but you only desaturate to 92% if you're African American adult. That doesn't get picked up. So this is literally, and I don't mean no pun intended, this is a sleeping giant of an unknown. And this is what scares me the most because I don't need to tell the audience the burden of sleep apnea in just the United States in terms of anywhere between 3 and 4% of the population. You may be severely underdiagnosing. And even if you're lucky enough to diagnose the patient, maybe they're not mild, maybe they're severe. And you could just take this to the nth degree. So yeah, this is a very scary issue for me, and I've been engaging some of the sleep medicine researchers to try to look at this, and they are. But again, it's literally the sleeping giant.
The manufacturers that sell us these devices, whether it be what's called a high resolution pulse oximetry, which I'm going to ask you about in a second as well, and the sleep testers that we can deploy in our offices to titrate our treatments of a diagnosed condition, are telling us that they're measuring fluctuations in 3 or 4% fluctuations, no matter where they fall on a scale. So if somebody drops from 96% to 92%, that's counted as well. So it's not just below 90s anymore. But that was the early days devices, yeah, for sure. So one of the uh, questions came in about high resolution pulse oximetry versus what would be called standard, and then there's consumer levels. And so, what about the sample rate? What do you say about that?
Well, here's part of the problem with that. And again, I like the idea of um, higher frequency checking, but if you're missing the hypoxia, you can increase the free. So you're going to just be missing the hypoxemia more frequently.
Mm.
It does not portend, it does not enable the workaround for melanin and the lack of patients with darkly pigmented skin being programmed into the calibration curve. And as far as I know, there's the 660 and the 940 spectrum of light are the only ones used. And that's the problem. The problem is you could change the technology and maybe pick a frequency of light that's not interfering with melanin, but the FDA hasn't gone that route and the device companies haven't gone that route because of the economics. Could you
Mhm.
imagine having to take all of those pulse oxes off the market and now you have to buy a brand new device? So until they change the spectrum of light, whether it's a high frequency event, looking at it, or the old legacy ones, it still falls prey to the calibration curve. And my pushback to the company would be, show me the data. Show me the data. Now, I do consulting for a bunch of the pulse oximetry companies. And when you do real world testing on the best pulse oxes on the market, they have inaccuracies. And these are the best companies, best intentions. So that tells you everything you need to know. Until a company comes out and shows a study that tells us there is no issue with skin tone on their pulse oxes, it's all lip service.
Hmm. So I'm involved with a couple of companies in our market that are trying to figure out how to do some monitoring with their devices in the mouth. And one company just made a big announcement that has a built-in oximeter on their device, their intraoral device for sleep apnea, that will allow us to measure or to gauge whether the device is working or not based on many variables around oximetry and pulse and those things. But it measures it off the maxillary anterior mucosa. What would be your thoughts about that?
Yeah, so that for me, that's exciting. The reason why it's exciting is there's a lack of melanin.
Ah,
There should be no interference with that. The only caveat would be, and it may not be totally applicable, is, and I didn't really delve into this. Again, this could have been a 2-hour talk. When you combine hypoperfusion or low perfusion states, that in and of itself can lead to inaccuracies of pulse oximetry. When you
mm,
combine that with skin pigmentation, it magnifies it. So in the mouth and the oral cavity, there's no melanin. So there should be less of an issue with that. And as long as your patient, again, I don't want to make up the data for them. I'd love to see it, but my take on that is that would be a reliable way to measure pulse oximetry and take the melanin skin tone off the table as long as they're well perfused. Now, I can't imagine you're going to have a patient in your office who's hypoperfused or in shock. But with that caveat, I'm excited to hear about that.
okay. Well, I can connect you with that company. You can ask them questions. They're pretty open about these things.
Yeah, I'm actually working with a company that it's a separate thing. They look at trauma and they have a bladder catheter in the bladder that they measure different things on during in trauma, where they can actually measure pulse oximetry because there's no melanin in the urinary bladder either. So this is very intriguing.
I'm hoping we don't have to use that route of
Yeah, I
testing
don't think your
for our
patients
oral
will be happy
appliances.
about that.
Yeah. So you answered a couple of the questions that came in already. Um, the because when oh yeah, I know what I was going to ask you is the devices that are being pitched to us as dentists. Do you feel like the manufacturers are taking advantage of the fact that we're dentists, so we're not as well trained in these things? And if so, what would be a pointed question we should ask a manufacturer who's trying to sell us an oximeter?
Yeah, that's a great question. You have to remember, and again, I don't want to, I do not want to talk ill of capitalism,
No.
but their role is to sell you devices. And I've heard all sorts of stories from device companies. Now you can get rambunctious and you can just ask them questions where you're not sure you're going to get reliable answers at all. My take-home message is, can you please show me the data on patients with darkly skin tone that you've tested this device on? Show me that.
Okay. So
And
we
then
should.
I'll and then I'll, and then I'll, and then at least we can have a point of discussion. But until you have that data, um, it's my assumption, not my assumption. I can tell you that based upon the literature, all pulse oxes have this issue. There's no company that's immune to it. Even the best pulse ox companies on the planet have issues with their pulse oxes because of this. So if that company has something different, they can be $1 trillion company if they put that data out to show that their device is not causing an issue.
What about another wavelength, like a green light wavelength? There's a couple of people that are touting that.
Yeah, it's interesting to say that. Again, I could have gone into a little history lesson, but green light was used in the past.
Hmm.
Now, here's the problem with green light. Green light does not really penetrate the tissue very well.
Hmm.
Green light is very good at taking a look at tissue oxygen state. It's not good at taking a look at pulse oximetry or arterial oxygen. The green light scatters and doesn't penetrate. So green light is good for if you want to measure tissue oxygen. And again, that's not really helpful for desaturations. It is helpful in other realms, but it's not really good. So green light was abandoned as a technology for pulse oximetry because of those inadequacies.
Okay.
And I didn't want to get into the difference between pulse oximetry and tissue oxygenation. Tissue oxygenation has a separate utility, but not for what we're talking about here, diagnosing sleep apnea.
Right. Right. Yeah. There's whole books about these things. So,
Yeah.
so what would a good practicing dentist who's trying to do the best, what can we use today? It meets the 2013 criteria. It doesn't meet your new ones, but we can't just say, well, we can't use it because it doesn't, do the right job. So, what's our best clinical effort?
Yeah, I get to ask this question a lot, and this is really tough. And I hate to walk away with there's not much you could do, but here's a real salient point. You have that patient in your office, you've done the right diagnosis and you're doing the right treatment and you got the right dental implant or device in there, and yet they're still symptomatic. And they happen to be Asian, Hispanic, or African American. You got to sit back and say, wait a minute, have I underdiagnosed this person's severity of sleep apnea? And maybe we need to investigate that a little bit more,
Hmm.
right? Now, if they're in your office, they're sleeping great, you've improved their sleep apnea. Okay, maybe the pulse ox, but they're not symptomatic and you're treating them. So it's for those patients who you're having persistent symptoms on, even though you're doing the best you can. That may be a patient who's failing, not because of you, but because of the technology. Now, what do you do about that? What you do about that is you may need to have a collaboration with your pulmonary colleague about, is there another way that I can possibly, maybe we have some occult hypoxemia going on here. Maybe we underdiagnosed the severity of this patient's sleep apnea. That's the best answer I could give, unfortunately.
Okay. And there was a lot of controversy in the last couple of years about consumer level technology, like Apple Watches is the primary one, where they came out and they said, okay, we can measure up blood oxygen, then we can't measure your blood oxygen. Now we can measure your blood oxygen again. What's your take on patients who come in and tell me, look, my watch says my oxygen is not good enough, or my Aura ring does, or my whatever the consumer level technology they purchased?
Yeah, so that's a tough one because I mean the data on I just gave you the data on the 10 best oximeters over them, and they weren't really good. Um, Now the all of those are designed for fitness and wellness, not for diagnosis and treatment. They should be using it for their treadmill or their walks, but not for diagnosis.
Okay.
So that patient that comes into your office and tells you, listen, my oxygen level's low, well, one of two things. Either the device could be right, and if you're worried that they're hypoxic and you're a dentist, you need to really refer them to a pulmonary specialist. And I don't want to scare them, but these things are, again, the reason they're designed for wellness and fitness is because they don't meet the diagnostic thresholds. And you can explain, and it's hard to explain that to a patient. Well, my oxygen says it's low. That could be true or not be true. You never want to dismiss a patient. You could never dismiss a patient. You'd say, hey, listen, if you're concerned enough about it, see your primary care physician. They may want to refer you to a pulmonologist. But if you're treating them for obstructive sleep apnea, then you may have a little more invested interest in that. And they may be that patient that you really do have occult hypoxemia, and it maybe pay attention a little bit more to them.
But we can't find that out as a dentist because there's just no technology that we can use for that.
No, and again, the best thing to do to protect yourself and the patient is to refer them back to their primary care physician to kind of investigate whether that's true or not. 99.9999% of the time, it's going to be a abnormal result that doesn't mean anything. But you don't want to be that 0.0000001% dentist who didn't refer the patient.
Do you think that the knowledge of pulse oximetry's limitations is widely known in physician communities?
Well, let me tell you, no. I've given anesthesia grand rounds, critical care grand rounds, pulmonary grand rounds, respiratory therapy grand rounds, nursing grand rounds. people, and I have a lot more data that's even more miserable than I presented. It literally blows them away. Even though this has been around since the 1990s, it's still, and which is why I go around the country and give these talks. My role is, my only role I have is to educate, to make people aware. I can't fix anything. But yeah, it really is it's sorely underappreciated.
Mhm. Well, I think you're doing a great job of getting us to appreciate the attention to detail that's necessary to be good doctors in what we're doing here, Dr. Cassiere. I really appreciate the time you spent with us today, and I'm very thankful for Panthera to sponsor this. I'll pitch them just a little bit because I think Panthera is doing one of the best jobs of any of the manufacturers in trying to help us be good doctors for our patients. And now that we find that, when we are trying to assess how things are going for our patients, then, kind of making sure that we are using the best equipment and presenting it in the best way, I think is probably part of your message that we can couple that with then our best efforts for keeping the airway open, helping people breathe better at nighttime. So I want to thank everybody for their questions, but we're out of time, although like Dr. Cassiere said, we could go on and on with this for a long time. If we did not get to your question, we'll answer it after the webinar via email. Within an hour, we'll send you a link to the replay of this presentation and instructions on how to access the CE quiz. Please be sure to complete the free CE quiz associated with this webinar to receive your continuing education credit. Thank you very much, Dr. Hugh Cassiere, and our sponsor, Panthera Dental. You bring us the best messages. Thank you for all, and be well.